hello, doctors. Please, good afternoon. This is Dr. Bruni from MedCognito, your brother, your friend, your partner in this whole MCCQE1 exam preparation. Kindly let me know if you can hear me well. Today, I want to make sure that we start off on a very good note. So please, let me know if you can hear me well because today's class is packed, packed. There's a lot we're going to cover. So let me know if you can hear me well. Just type in the comment section. Yes, I can hear you. Yes, I can hear you. And please make sure that you are inviting as many friends as possible to join us. So please let me know. Can you hear me? And if you can hear me, is it clear? So two things. Yes, I can hear. Number two, it's clear. Yes, I can hear. Number two, it's clear. Yes, I can hear. And number two, it is clear. And I'll be looking at my other screen to make sure that um we get all the comments. Okay. Yes, I can hear. And number two, clear. And you can also see that your comments on the page as well. So whatever you type, you can also see yourself on the on. We want to make it as inclusive as possible so that we can all enjoy, this experience. Beautiful. Okay, so let me share my screen. Hope you are well. Hope you are doing well. Hope you are doing very well. I'm going to share my screen and we'll get into it. Today we're dealing with approach to CVA, okay, cerebrovascular accident. And there are so many aspects of this particular topic, but what we're going to do today is, you know, um, how to deal with differentials of CBA, initial assessment, some very, very important things that you need to know. So please make sure, number one, if you have friends who have not joined us yet, let them know the class is going on. Okay, share it to the various WhatsApp groups you have, Telegram groups. Let them join. Let us study together. This is our give back to our IMG and IPT community. All right. So it's, and if you want to speak to me, my number is what's rolling below the screen. I prefer that we communicate by WhatsApp so that I can connect with you to you wherever you are joining us from the world. So it's +1 306 891 5649. +1 306 891 5649. So I see Dr. Sabine um just said hi, Dr. Bruni, Dr. Zulu as well, Dr. Joanna Cruz. Oh, beautiful. Dr. Peter Brown is joining us as well, Dr. Um, you know, everybody. We have Dr. Ikuna. So please make sure that you are joining us, get some water, and then also say I prefer that you send me pictures of where you are joining us from. Okay. Whether you are in your sitting room, some people will be looking out the window while they are listening to this lecture. Some people will be casting it on their TV. I'll be very glad to share that experience with you as well. So let me share my screen and let's get the ball rolling. Let me share my screen. Good. And Dr. Isaac is back. He says, hello, King. Beautiful, beautiful, beautiful. Dr. Isaac, thank you very much. It's always a pleasure to serve you. Always a pleasure, always a pleasure, always a pleasure to serve you. So, um, yeah, we just get the ball rolling. Okay. Can you see me? I just want to make sure you can see me. Yeah. This is no, but this one you can see as well. So, yeah, let's just go with this. Okay. All right. So I think we're good to go. So doctors, let's get the ball rolling. So approach to CVA. Why are we dealing with this topic? It's a very important SQ1 objective. And there's an objective entitled cerebrovascular accident and transient ischemic attack. Okay. That's an MCQ1 objective. That is why we are dealing with this. And it's also good for those who are going for the NAC OSCE exam because the NAC OSCE exam objectives also follow the same MCCQE1 objectives. Okay. The only thing is that in MCQ1, you are solving 230 questions, MCQs. In the NAC OSCE, you are doing 12 questions. The NAC OSCE, you are speaking. The MCQ1, you are doing MCQ exam. But it's the same objectives you are following. All right? Okay, good. So the rationale for this is that transient ischemic attack and cerebrovascular accident consist in the acute loss of arterial blood flow to a part of the brain or brain stem, resulting in temporary permanent loss of function. Okay. Now, transient ischemic attack and CVA are among the most common causes of death and disability in Canada. So it comes back to everything we've been talking about. Everything we've been talking about. Everything we've been talking about. The MCCQE1, the NAC is testing you on common things which can easily kill the patient, and things which the candidate should be able to handle easily. Okay, at least pick up and give some treatment to this particular patient. So lifestyle and risk factor modifications are ways of preventing these disorders. So if you are using the great system, you realize that now they are throwing in public health and preventive medicine principles here as well, lifestyle and risk factor modifications, and which can be treated with urgent medical or surgical intervention in some cases. Okay. Now, the causal conditions, then they'll state that the list is not exhaustive. So, ischemia, so these are the causes of cerebrovascular accident. We can have ischemia, that is taking blood flow to the brain, and then we can also have hemorrhage, that is bleeding, right? So, the ischemic causes, please, I need you to take notes because, like what we've been doing in the last 2 weeks, we are doing active recall as well. Let me see. Dr. Rockefeller said, loud and clear, Dr. Boni, Akwaba. Well, Akwaba means welcome in my language. Okay, I'm from Ghana. And Dr. Rockefeller is also from West Africa. And he's trying to let me know that, he understands my language. Beautiful. So Akwaba. So if you see a Ghanaian and you say Akwaba, that means welcome. All right? Dr. Rockefeller, that's wonderful. And another cause of stroke is hemorrhage, that is bleeding. And with the hemorrhage, we have intracerebral hemorrhage and subarachnoid hemorrhage. And part of today's class will also deal with, how to even differentiate between thrombotic stroke from embolic stroke, from intracerebral stroke, from subarachnoid hemorrhage. We'll look at all these things, how you can deal with all these things in the exam. All right? Okay, good. So it goes on to say that given a patient with acute neurological deficits, like aphasia, like amaurosis fugax, the candidate will obtain an appropriate history and perform a physical exam, leading to the possible diagnosis of transient ischemic attack or cerebrovascular accident, and take action. And the candidate will recognize the need for preventative health care in order to decrease the risk of TIA or CVA. So it comes back again. Transient ischemic attack, CVA, and prevent. So you realize that if you are learning this, one thing you need to learn is the public health side of how to prevent transient ischemic attack and cerebrovascular accident, as well as cerebrovascular accident itself. Okay. Now, the enabling objectives: giving a patient with risk factors for transient ischemic attack or cerebrovascular accident, the candidate will, number one, list and interpret critical clinical findings, including result of the history and physical examination, aimed at detecting an early pathology like bruit, like hypertension, that is treatable or correctable. Number two, giving a patient with acute intermittent chronic neurologic deficits, the candidate will list and interpret critical clinical findings, including results of the history and physical exam, aimed at determining whether TIA is a possible cause. And then list and interpret critical investigations, including imaging like CT, laboratory testing like lipid profile, and construct an effective management plan, including proceeding with acute or chronic medical and surgical interventions, for example, blood pressure control, and referring for specialized services like rehabilitation, speech and language therapy, and anticipating medium and long-term complications like psychosocial impact and safety, right? So these are all things we need to cover, but we will not be able to cover everything today. So for today, we will do a broad overview. So that should have been a broad overview of strokes and how to evaluate a patient with stroke. That's what we'll be doing today. Let me just go in and correct that, there should be an O there. Okay. Broad overview of strokes and how to evaluate patients with stroke. Okay. So now, as we do, let's start with a question. You have a 72-year-old woman who presents with 15 minutes of left arm weakness and facial droop that resolved just before arrival. Her vital signs are normal. A non-contrast PET CT is unremarkable. Which of the following statements is most accurate? A. Her resolved symptoms confirm there was no ischemia. B. She does not require urgent workup since symptoms have resolved. C. A hemorrhagic stroke is the most likely cause. D. She likely experienced a transient ischemic attack and needs urgent evacuation. And E. Altiplase should be administered immediately. So what's the correct answer? So I see a lot of doctors are going for D. D. She likely experienced a transient ischemic attack and needs urgent evaluation. So the way the patient presented, symptoms came on and then it resolved. Wow, somebody's joining us from Hong Kong. It's beautiful. Somebody is joining us from Hong Kong. The person says it's almost 2 a.m. in Hong Kong. That's powerful. Doctors, a lot of you are making a lot of sacrifices to make sure you ace this QE1. And I really appreciate this. And this is what keeps us going. Because some people say, Dr. Boni, why do you give so much content in your live free class? I'm like, you know what? I have committed myself to do this. For somebody to stay up at 2 a.m. and listen to us from Hong Kong, we need to make sure that we are giving off our best and we are not just, blowing off hot steam. We are giving off our best. So this patient's symptoms, which just resolved, this is a classic case of transient ischemic attack. And you realize that the symptoms suggest that there was a focal brain ischemia, but it has resolved. And even though the symptoms are gone, she's at high risk for a stroke, and she still needs urgent evaluation. And so, one lesson I want us to pick up, and I want us to write this down in our books, is that the fact that somebody has had symptoms and the symptoms have resolved does not rule out ischemia. It does not rule out ischemia. Okay? And if a patient's symptoms have resolved, there's no need to give altiplase. There's a place for altiplase. And when we are going through the class, you will come back. But for this situation, we don't need to give altiplase. Next one. You have a 58-year-old man who presents the ED acute aphasia and right hemiparesis that began 90 minutes ago. What was the most important immediate step in his evaluation? A. MRI of the brain. B. CBC and coagulation profile. C. Electrocardiogram, that is ECG. D. Non-contact CT of the head. And E. Carotid Doppler ultrasound. Carotid Doppler ultrasound. Okay, while you are answering this question, yeah, Dr. Belaine Terry says, wow, yes, doctor, look, you'll be surprised at the kind of sacrifices people make. I know some candidates who delivered and went to write the exam the next day and still passed. They delivered the baby, went to write the exam the next day and still passed the QA1. And you know what? It's wild. It's wild. In fact, I'm working on a YouTube video to talk about what we go through as international medical graduates, and how we are still doing our best to overcome all the difficulties to still write the exam. So for me, for somebody to come at 2 a.m. around this time to be joining this class, it's a blessing. And that is why we can't also disappoint such a person, right? We have to make sure that the time we are spending together is worthwhile. So what's the correct answer? The correct answer is D, non-contrast CT of the head, right? The critical first step in acute stroke is to rule out whether there's hemorrhage, and you've got to use a non-contrast CT. And you realize that the non-contrast CT is what's going to help you to know which direction to go. Because if there's hemorrhage, you have to use a different treatment plan. If there is no hemorrhage, you have to use a different treatment plan. Okay, yeah. And this determines whether thrombolytics can be safely given. So, because if you don't do the head, the non-contrast CT, and you go on to give thrombolytics in a patient who is already bleeding, you're in trouble. Okay? Now, why don't we do an MRI in a patient who has an acute stroke as a first line? There's a place for MRI, and how we go to the class, I'm going to talk about it. But MRI is more sensitive. It takes longer, okay, and is not the first line in acute settings. And remember very well that in the MCCQE1, one of the things you need to focus on is um, one of the things you need to focus on is first line, next best steps. Okay, so please, this is something I want you to focus on when you're preparing for your exam. Doctors, please, can you hear me clearly? Can you hear me? Because I just got a notification from somebody that they can't hear me. Mr. Sabine says, your voice is breaking. I want to make sure that I pause here. Can you hear me? If you can hear me, let me know. If you cannot hear me as well, let me know. Not clear. Okay. All right. Okay. Not mistake. What can I do today? Let's um okay. So I've changed the microphone. Can you hear me now? I've just changed the microphone. Can you hear me now? Doctors, please, can you hear me? Can you hear me now? I've just changed the microphone. Can you hear me? I want to make sure you can hear me before we move on. Okay, now better. Beautiful. Okay, sure. If it's better now, then let's continue. Okay. If the voice is better now, does it sound like it's far away or it's good? Can you hear it clearly? Beautiful. Okay, good. Thank you very much, Dr. Sabine and Dr. Ben, who informed me that they can't hear. And I think another doctor also said the same thing. Dr. Isma, yeah. Okay, Dr. Isma said, yeah. Okay, so remember that non-contrast head CT scan is the first line, right? Non-contrast head CT is the first line. However, there's an indication for MRI, and I'll come to that. Why is CBC not the first line? CBC in coagulation can be helpful, but it's not the top priority. ECG helps us to determine the etiology, especially if it's a thrombotic stroke, right? If the patient has an atrial fibrillation, we can pick it up on the ECG. And carotid Doppler is for secondary stroke prevention, not in the acute setting. So in the acute setting, so far as the patient is, stable, get your CT scan as quickly as possible. Okay, get your CT scan. Okay, so you have a 60-year-old woman who presents with right-sided weakness and visual disturbance for the past 3 hours. This patient is hypertensive, okay, and tachycardic. CT scan shows no hemorrhage. What further step will help identify the cause of her symptoms? 60-year-old woman presents with right-sided weakness and visual disturbance for the past 3 hours. She's hypertensive. She has tachycardia. Okay. CT scan shows no hemorrhage. No hemorrhage. What further step will help identify the cause of her symptoms? What further step will help identify the cause of her symptoms? A, lumbar puncture. B, repeat CT scan in 24 hours. C, carotid artery Doppler. D, glucose and electrolytes. And E, chest x-ray. What further steps? So you've done your CT scan, remember, it shows that there's hemorrhage. Now, after your CT scan, what further step will help you to identify the cause of her symptoms? Is it A, lumbar puncture? Is it B, repeat CT scan in 24 hours? Is it C, carotid artery Doppler? Is it D, glucose and electrolytes? Or is it E, chest x-ray? And I see a lot of candidates going for C, carotid artery Doppler. I see a lot of people are going for C, carotid artery Doppler, and that is the truth. Once the patient is stabilized and stroke is confirmed that this is ischemic, the next step is to identify the source, okay? And this may include carotid imaging or cardiac evaluation. So carotid imaging is when you do your carotid Doppler ultrasound, and the cardiac evaluation is when you do your ECG or your echo. Why? Because when you're doing the ECG or the echo, it helps you to know or look for the source. The ECG, as I said before, can help us to pick up something like an atrial fibrillation so that we will know that, no, there's a problem going on in the heart. So while we are dealing with this patient's stroke, we also need to make sure that we've rate controlled the patient and, we are getting things under control. Now, what is the indication for lumbar puncture in the case of a stroke? The indication for lumbar puncture in the case of a stroke is if you suspect subarachnoid hemorrhage. Subarachnoid hemorrhage. So if you suspect subarachnoid hemorrhage, yet the CT scan is negative, then go ahead and prepare and get your lumbar puncture. So there's a place for MRI, there's a place for lumbar puncture, there's a place for CBC, but all these should not come before getting your CT scan. Okay, good. So now, in evaluating a patient with suspected stroke, why is it not reliable to use the presence or duration of symptoms to determine whether an infarct has occurred or not? Why is it not reliable? A, all strokes present with permanent symptoms. B, symptoms that resolve quickly indicate seizure, not stroke. C, brain infarction cannot occur without prolonged symptoms. D, the tempo of symptoms does not correlate with infarction or etiology. And E, only MRI can confirm infarction in acute stroke. What's the correct answer here? What's the correct answer? Doctors, please answer the question. So I see some people went for C, but then the correct answer is in reality D. The tempo of symptoms does not correlate with infarction or etiology. The tempo of the symptoms does not correlate with infarction or etiology. Okay? In cases of cerebrovascular accidents, symptoms may resolve or persist, but this does not reliably indicate whether infarction has occurred. How quickly the symptoms improve does not reliably indicate whether infarction has occurred or not. Okay? Now, rapid resolution doesn't rule out ischemia, and the symptom pattern does not clarify the underlying cause. Somebody has a question for me. He says, how can we get those questions in NAC OSCE, Dr. Bruni? Which questions? I don't know which questions you're talking about, Doctor. Yeah. So, and remember that we learned a trick that when you see the word all, you want to be very careful. All strokes, all strokes cause permanent symptoms. That is false as well. In an exam situation, you want to run away from absolutes, right? Okay, good. So let's do a deep dive to the introduction of CVA. Introduction. Let's do a deep dive right away. Okay. So when you're thinking about cerebrovascular accidents, think about this foot track. Think about this foot track. Okay. Think about the fact that this foot track has to come to Edmonton or has to come to Toronto or has to go somewhere. Okay. And then you see here that there are blockages on the way. Okay, so think about the human brain as a city which needs food supplies. And then think about the blood as the delivery track. So Edmonton is the brain, the delivery track is the blood, and the blood vessels are the roads. Okay, now if a road to Edmonton is blocked or damaged, what will happen is that it's going to affect the delivery of food to the city. And therefore, it will cause the neighborhood to suffer. Okay? And that is what we call brain ischemia. So just think about it. The bus which has to send the food to the city is blocked. And therefore, the bus cannot take the food in there. Why is it blocked? Because something called a stroke is happening. It is blocking the road. That's the easy way I can explain this. So what can happen to a blocked road? Remember that if the road is blocked and then you call the police quickly, the police can come in and get the doctor. Sorry, I think somebody's trying to call through this. Please, let me just tell person that I'm teaching. Okay, so if there's a blocked road, two things can happen. We can call the police quickly to come and help move the traffic. Okay, we can call the police to come and move the traffic quickly. Or if the police do not come to remove the traffic and then the road remains blocked for weeks, can you imagine, like Edmonton needs food and we are not getting the food there? What then can happen is that the people in Edmonton will start suffering, right? So just think about it in that way. If you're thinking about a stroke, the roadblock can be dealt with quickly, and that will then give you just transient symptoms, and that's what we call the transient ischemic attack. Or if that doesn't happen and the road remains blocked for a long time, then we can have the sequelae of long-term blockage of the road, and that is what can lead to a stroke. All right. So this is why it's a big deal to know the cause of the brain damage in case of cerebrovascular accident, because treatment will depend on the cause. So, for example, you have to just ask yourself in an exam situation, in your MCCQE1, in your NAC, OSCE, this case have been given. Is it a blood clot or is it a blood bleed? If it's a blood clot, you may need to get some clot busting, medication. However, if it's a bleed, you don't want to give a clot busting medication. Because if you give a clot busting medication, that can even make things worse. Because we learned that in strokes, it can be a block or it can be a bleed. And they have two different ways you want to manage them. Okay? So there are two broad categories of cerebrovascular accidents. Number one, it could be a blockage, which is an ischemic stroke, or it could be a bleed, which is a hemorrhagic stroke. An ischemic stroke is basically the fact that the pipe is blocked or there's a clot. And a hemorrhagic stroke means that the pipe is burst and there's a bleed. So please always think about it in this way. Please, does it make sense? I have a question with the food analogy, the track analogy, and then the fact that we are talking about the two broad categories. Does it make sense? Because we need to make sure that we understand this in order to build on it so far as management is concerned. So I want to know from the comment section, does it make sense? Let me know. Does it make sense? That's what I'm saying. That's what I'm sharing. Does it make sense? Okay, beautiful. All right. So now, let's master the subtypes of stroke because the MCC wants us to do that. Let's master the subtypes of stroke. So you've got to be able to differentiate between four main types of stroke in your MCCQE1 exam. Four main types of stroke in your MCCQE1 exam. Okay? Someone says it's as clear as water. Dr. Dogua says it's as clear as water. Beautiful. So you've got to be able to differentiate four types of stroke. So I'm going to quiz you a little bit on it so that we can be able to pick up any of them in the MCCQE1 exam. Okay? So I'm going to just start from intracerebral hemorrhage. You must be able to tell from the way the question is presented. Does this patient have intracerebral hemorrhage? Does this patient have subarachnoid hemorrhage? Does this patient have ischemic stroke? And remember that the ischemic stroke, it can be thrombotic or it can be embolic. And we are going to break it down step by step in this class. So let's start with some MCQs to deal with these things. You have a 54-year-old woman who collapses at the gym during a spin class. So she's going through spinning. Spin class. And she's found unresponsive with unequal pupils and vomiting. Now, in the emergency department, her blood pressure is 210 over 110 millimeters of mercury. And she does not regain full consciousness. Which stroke subtype is most likely? Which stroke subtype is most likely? Number one, ischemic stroke, which is thrombotic ischemic stroke. Number two, embolic stroke, which is ischemic embolic stroke. Number three, subarachnoid hemorrhage. Number four, Intracerebral hemorrhage. Number 5, vertebral artery dissection. What's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? Doctors, I'm waiting for your answers. So I see a lot of D's. I see a lot of D's. Dr. Bironke went for D. And then I've started seeing some E's. Dr. Justus Akere is going for E. And then I see some C as well. Dr. Chimreze Mwamo is going for C. What is the correct answer, Dr. Bruni, and why? The correct answer is D. 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 So all those who got D, that is the correct answer. Because, it's intracerebral hemorrhage. Let's go back and look at the case very well and look at why. Gym class, spin class. So probably she's exerting herself somehow. She's unresponsive, unequal pupils, vomiting, blood pressure is high. Okay, so this scenario we just described, it goes through a gradual onset of stroke during physical activity, okay, with decreased alertness and vomiting and a very high blood pressure. Please, I need you to write these things down. And the cluster of symptoms is classic for intracerebral hemorrhage, okay, especially if the patient is hypertensive. Now, why is it not a thrombotic stroke? Let's use this slide to learn, because the other questions which follow will follow a similar pattern and we have to be able to tell. Thrombotic strokes usually have a stuttering onset. The question will describe it like it's not just boom like that. Okay, embolic strokes usually are sudden. So embolic stroke, just think about an embolus, like a pulmonary embolism. Like just think about the way blood clot can travel from the leg. It can travel from the leg to the lungs. In the same way, blood clots can travel from the heart into the brain. Okay, usually embolic strokes are sudden, but the patient does not have depressed consciousness. So write that one down, because in the board exam you should be able to separate all these types of strokes. And in subarachnoid hemorrhage, that is when the patient will say, "This is the worst headache of my life." Severe headache, but often they may have preserved alertness initially. So in subarachnoid hemorrhage, look for that word, like the worst headache or very severe headache, that kind of thing. Okay, and vertebral artery dissection, this is where Dr. Justus went for. Vertebral artery dissection usually causes brainstem or cerebellar signs, not coma. So doctors, let me pause here so you can breathe on this information I'm just sharing. I'm just pausing here so you can breathe on this. On this information I'm just sharing. Please, breathe on it. Breathe on it. Breathe on it. Breathe on this information, because there's so much information in this one slide. Thrombotic strokes have a stuttering onset. Embolic strokes usually may present with focal neurologic deficit without depressed consciousness. Okay, subarachnoid hemorrhage, the patient will say, or in a board exam, you'll be told that is the severe headache or the worst headache in the patient's life. And initially, there may be preserved alertness. Okay, and vertebral artery dissection may cause brainstem or cerebellar signs, not coma. Okay, let's go to the next question. You have a 45-year-old man who presents with sudden severe headache. Now, that is one clue. Worst headache of my life after sneezing. He's alert but photophobic and nauseated. His blood pressure is 150/90. No focal neurologic deficits are noted. What's the most likely diagnosis? A, ischemic stroke, which is embolic. B, subarachnoid hemorrhage. C, ischemic stroke, which is thrombotic. D, migraine with aura. And E, intracerebral hemorrhage. So this one, it gives it away because we've just explained it in toto, in detail, in the past slide. And this is an answer of subarachnoid hemorrhage. The worst headache of my life, right? Next question. 68-year-old man with hypertension and diabetes presents a left arm weakness that fluctuates over the past 24 hours. Look at the way the question is being put. Symptoms have worsened overall. He has a history of smoking. Vitals are stable. Which type of stroke is most likely? A, subarachnoid hemorrhage. B, ischemic stroke. C, ischemic stroke thrombotic. C, ischemic stroke embolic. D, intracerebral hemorrhage. And E, transient ischemic attack. What's the correct answer? What's the correct answer? And the correct answer is B. This is ischemic stroke. Remember that we said one thing you need to note is that ischemic stroke has a stuttering progression. Okay, so it gets better, gets worse. Now, in the last 24 hours, stuttering. Doctors, please, I have a question. Is this session helping you to now break down the various types of strokes? I want to know. Is it helping? Is it helping at all to break down the various types of stroke? Is it helping? Because, initially we every stroke, but in a board exam, it's a totally different ball altogether. Okay, good. It's a total different ball game altogether. Okay, good. So transient ischemic attack usually resolves in 24 hours, but this patient's stroke seems to be worsening. So it's not a transient ischemic attack. This looks like a thrombotic stroke. Okay, good. So I have a 62-year-old man with a history of atrial fibrillation, wakes up from sleep with slurred speech and right arm weakness. The symptoms begin suddenly and are maximal at onset. His symptoms begin to improve en route to the hospital. What's the most likely stroke subtype? What's the most likely stroke subtype? Dr. Bironke has already written her exam, but she's still coming for class. And she says that we're still learning even after passing the exam. She's still coming for class. That's beautiful. Okay, that's very, very good. So this patient, atrial fibrillation. So atrial fibrillation and stroke, what is the link? The correct answer is what? The patient is going to throw an embolus. So this is ischemic stroke secondary to an emboli. This fits an embolic stroke. Okay, sudden maximal symptoms at onset, often in atrial fibrillation patients, and rapid improvement is common as the embolus may fragment or dissolve. Okay, next question. You have a 60-year-old black man who presents after collapsing during sex. Oh my goodness. This guy was found in the line of duty and he collapsed. He's drowsy. He has right-sided weakness and a blood pressure of 220 over 150 millimeters of mercury. He has a history of poorly controlled hypertension. And what's the most likely cause of his condition? A, subarachnoid hemorrhage. B, ischemic stroke, which is embolic. C, ischemic stroke, which is thrombotic. D, intracerebral hemorrhage. And E, vertebral artery dissection. So this gentleman, and that's another thing you will see, he collapsed during sex and blood pressure is high. And the correct answer is D again, D again, D again, D. This patient presents with stroke during exertion, right? And he has altered alertness and extreme hypertension. And you realize that intracerebral hemorrhage, another pearl you need to learn for the exam, is more common in black patients with chronic hypertension, intracerebral hemorrhage. Okay. So now that we've finished these questions, let's do a deep dive. So far as those topics are concerned. So Again, imagine that your brain is like a city, right? Blood vessels are the roads which are delivering oxygen, and a stroke happens when something blocks or bursts. Let's meet the 4 types of stroke, the 4 culprits which can cause traffic chaos in your city, which is your brain. So let's start with the intracerebral hemorrhage. So the intracerebral hemorrhage, I call it the bursting pipe inside the city. This one, there's a big pipe in the city and it just boom, or there's a big road in the city and it just boom, broke. That's the intracerebral hemorrhage. So you realize that it's affecting, the brain parenchyma itself. Okay, and that's why I showed this picture. Now, intracerebral hemorrhage, what's actually happening? You have a blood vessel which is deep in the brain, which bursts, and it is spilling blood and pressing on the brain. Okay, this is not a blockage, it is a bleed. Intracerebral hemorrhage is a bleed. Now, the clues are that there can be gradual onset, but worse over minutes to hours. It may start suddenly with full-blown symptoms, okay? And it often happens during physical activity like sex or exercise. And the patient may look drowsy or less alert. And neurologic symptoms usually increase gradually over minutes or a few hours. So that is the secret about the intracerebral hemorrhage. This is a big pipe. Just think about it. Lining the brain. So that's a blood vessel, right? It bursts and then the blood starts seeping into the brain, right? And it is not a blockage, it's a bleed. Now, what are the risk factors for intracerebral hemorrhage? Severe hypertension, trauma, illicit drugs like cocaine, amphetamines. Doctors, please write all these things down. Bleeding disorders or vascular malformations. So maybe the road was bad already, right? Amyloid angiopathy. As well, there can be vascular malformations. So the patient could have a brain tumor and there's a bleed into the tumor. Or there could be an aneurysm which ruptures. Or there can be vasculitis. It is more common in Asian people and Black people. And so, how do you memorize this? High pressure will pop your pipes. Basically, high pressure, that is high blood pressure will pop your pipes. So hypertension will lead to high pressure, it will pop and there can be bleeding. So that is it, intracerebral hemorrhage. That's how you have to look at it. Now let's look at subarachnoid hemorrhage. Please, doctors, before we move on to subarachnoid hemorrhage, are we all okay with the intracerebral hemorrhage explanation? Please, are we all okay with it? Intracerebral hemorrhage explanation. Are we all okay? Because we are now going into all the 4 types of strokes, and I want to make sure that we are all on the same page before. Okay, so I see a lot of yes, yes, yes. Okay, so if you're okay with that, then let's move on. So now let's talk about subarachnoid hemorrhage. Subarachnoid hemorrhage is the lightning strike headache. That's what I call it, the lightning strike headache, right? So in subarachnoid hemorrhage, what is happening? There's a vessel which has burst, but it is near the surface of the brain, and it is leaking blood into the space around the brain, not into the brain tissue itself. So intracerebral hemorrhage, it was going into the brain tissue. Subarachnoid hemorrhage, it is going onto the surface of the brain tissue. Okay, so there's sudden severe headache. The patient will say, this is the worst headache of my life. It may happen during sneezing or sex or straining. So maybe the patient has some benign prostatic hyperplasia. He goes to the washroom, he's just straining, that kind of thing. Or he has very bad constipation. He's not drinking any Restorelax or anything, and he goes to the washroom and he's just straining. And then all of a sudden, boom. Okay? They are not always weak or paralyzed. The brain function might be okay at first, all right? But they may feel nausea, neck stiffness, or become drowsy. Okay? Now, what are the risk factors of subarachnoid hemorrhage? Smoking, hypertension, heavy alcohol use, family history of subarachnoid hemorrhage. And if you get a situation where you see a patient who presents with a stroke, but you're not really getting any detailed information apart from the fact that the patient has a genetic kidney condition called polycystic kidney disease, that should draw your attention to the likelihood that this patient has suffered a subarachnoid hemorrhage, as well as cocaine. Okay, so in subarachnoid hemorrhage, think about sudden, awful headache, sudden, awful headache, sudden, awful headache. Okay, causes subarachnoid hemorrhage if the patient may have an aneurysm, so vascular malformations, bleeding, diastasis, trauma, even amyloid angiopathy, and illicit drug use. So subarachnoid hemorrhage, this is the worst headache of my life, sudden, awful headache. Again, doctors, before we move on, subarachnoid hemorrhage, does it make sense? Does it make sense? I want to know. Subarachnoid hemorrhage, does it make sense? Awesome. Awesome, awesome, awesome. Now let's move on to the next one. Ischemic strokes. Now, the ischemic stroke, remember that we have the thrombotic type and the embolic type. So the thrombotic type is thrombosis. It's a slow building traffic jam. Okay, just think about it. Slow building traffic jam. Slow building traffic jam. Okay, so in all these, remember that we are taking food into the city. The track is the blood. The road is the blood vessel. And what is in the track is like the oxygen and the rest, right? We've learned about the hemorrhages when the road bursts. Now we are learning about what can block the road. So ischemic stroke, thrombotic type. This one, look for, that patient who has slow building traffic jam. So ischemic stroke, what's happening in a thrombotic stroke? A clot slowly forms inside the brain artery, usually over atherosclerotic plaque. So in the thrombotic stroke type, there's usually an atherosclerotic plaque. And the brain is therefore starved of blood. And then it leads to symptoms that come and go, and then eventually it worsens. Okay? The symptoms come and go, and then eventually it worsens. That is a thrombotic type. Remember that it is like traffic is building up gradually. Traffic is building up gradually. Then, boom. Okay? So, that is why it has the stuttering symptoms. They get better and then it gets worse. And it can take hours or a few days for us to see the full evolution of the stroke. All right? And the patient may have had mini strokes before, transient ischemic attacks before, right? And in this case, that is when, if you do your carotid Doppler ultrasound, you may hear a neck bruit. You may hear a neck bruit. What are the risk factors? Atherosclerosis, so like smoking, diabetes, high cholesterol, increased age, male sex. So the thrombotic type of stroke, think about the fact that the symptoms are trickling, like the way the traffic jam is building up gradually, and then boom, then there's trouble. Okay, so doctors, again, let me pause here. Does it make sense? We've looked at intracerebral hemorrhage. We've looked at subarachnoid hemorrhage. Now we're looking at ischemic stroke, and we are looking at thrombotic stroke, where the traffic jam is building up gradually, and then boom. So you realize that most of the time, when patients have transient ischemic attacks before a major stroke, it is linked with thrombotic strokes, right? Okay, good. Next one. Ischemic stroke, that is the embolic type. Doctors, please make a lot of notes. Embolic type. The embolic type is the one you think about, a sudden missile attack. Because in war, a missile, when a missile is thrown, there is a source and there's a target, right? So the embolic type, the source is the heart and the target is the brain. So it goes, so it goes from the heart. It goes from the heart to the brain. They launch the missile from the heart, and then the place of attack is the brain. The missile is drawn from the heart and it goes to the brain. So That is why I call it the sudden missile attack, right? So what's happening? There's a blood clot and it travels from the heart or large vessels and suddenly will block the brain artery. And then the brain will suffer instantly, right? The source is the heart, the target is the brain. That is it. Okay, so what are the clues? Sudden onset with maximal symptoms right away. Because when a missile is thrown, what happens? Boom, it just destroys, the place, right? And it may improve quickly if the clot dissolves or breaks up. And it can happen at night or with coughing or sneezing. So the patient is brewing the clot in the heart. He's brewing the clot in the heart. And then something happens. And then it goes to the brain. Boom. Trouble. Right? So what are the risk factors? So that's why I showed this missile. And I said the missile has a source, which is the heart. The target is the brain. So what are the risk factors? Atrial fibrillation, heart valve disease, endocarditis, and same risk factors as thrombotic stroke as well, like smoking, increased age, diabetes as well. So the mnemonic is that embolic strokes, there's an emergency missile from the heart, which is thrown from the heart, then the target is the brain. Doctors, please, I hope this simple explanation helps to break everything down for you. Does this simple explanation help to break everything? Hemorrhagic stroke, embolic stroke, okay, subarachnoid hemorrhage, and then thrombotic stroke. So let's use this table to summarize everything. How are you going to remember it? Intracerebral hemorrhage. Look for that patient with very high blood pressure. Their head is down, gradual worsening, and the patient may have coma, increased blood pressure, and their alertness is low. Okay? Embolic stroke is explosive and it's an emergency right away. It happens suddenly, maximum deficit. Look for that patient with atrial fibrillation. It can also improve quickly if the clot is busted or if the clot is dissolved. Aneurysmal stroke, that is subarachnoid hemorrhage, the worst headache in the patient's life, right? It may be triggered by activity. It presents with a thunderclap headache. The patient may be alert at first and then they may lose their consciousness. And then dripping thrombotic stroke, it's dripping, gradually, and then the traffic is building. Why? Because of that atherosclerotic plaque. And the symptoms may be delayed and it is stuttering, right? And when you listen to the neck, you may get a bruit. And the patient may have a transient ischemic attack history. Doctors, I have a question. So far, how has the class been? So far, how has this class been? So far, how has the class been? Good. 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 Amazing. Beautiful. Okay. So now, let's look at the differential diagnosis of stroke. Let's do some MedCognito calculations. This one, I'm not going to give you MCQs because MCQs you can also guess, right? I will provide the equation and you provide me the answer. Differential diagnosis of stroke. Differential diagnosis of stroke. I'll provide you the equation, you provide me the answer. Let's go. So we are going to look at the various conditions which mimic stroke, right? So you have a patient who presents with visual aura, gradual spread of the visual aura with headache. Usually you see this in young people. What diagnosis am I talking about? What diagnosis am I talking about? Visual aura with headache, which can mimic stroke. What diagnosis am I talking about? By the way, doctors, please, while we're on this call, please, if you are, and a lot of you are watching on YouTube, we have 121 people on the YouTube right now. Please, just click on the like and the subscribe button right now. The like and the subscribe button, please help us to grow our YouTube channel. We are doing this for you. And if you're able to help us to grow it, then others can also see what we are sharing. Because we want to get the good news of MedCognito to the whole world, right? We want to get the good news of MedCognito to the whole world. We want to get the good news of MedCognito to the whole world. So please, kindly click on like and subscribe right now. Like and subscribe, please, please, please. Like and subscribe. Like and subscribe. So far, we are at 2,577 subscribers. Let's move it to 2,700 subscribers by the end of this class. 2,700 subscribers. Let's do that. Let's move it to 2,700 subscribers by the end of this class right away. Okay? 2,577. Let's move it to 2,700 subscribers. Okay? Because the more you subscribe, then the more others get to hear about it. Okay. So now, let's look at this. Visual aura, gradual spread, headache, usually in young people. What's the answer? This is very simple. The answer is what? It's migraine, basically. So migraine is one of the differential diagnoses of stroke. That is migraine with aura. Some people can present with very severe migraine. You may think that they are having a stroke, actually. So that is the answer. Okay? So all those who got migraine correct, beautiful. Next question. You have a patient, you don't know, does this patient have a stroke or not? And the patient has jerking limb movements, post-event weakness. The patient had jerking limb movement, and then after that, the patient is weak. What differential of stroke are we thinking about? What differential of stroke are we thinking about? And this happens after a seizure. What differential of stroke are we thinking about? Jerking limb movement plus post-event weakness, and it happens after a stroke. I can see some people putting in some answers. Seizure with thought paralysis. Beautiful. So Dr. Luke Ododu, beautiful answer. Seizure with thought paralysis. Okay. Next differential. Doctors, so you see, we've changed the format the way this time I want you to provide me the answers. Okay. Next question. The patient has slow onset of focal signs and there's mass lesion on CT scan or MRI in the brain. What's our differential diagnosis? What's our differential diagnosis? The patient has slow onset of focal signs and there's mass lesion on the brain. What's our differential diagnosis? What's our differential diagnosis? What's our differential diagnosis? What's our differential diagnosis? And this can be with or without fever. Okay. What's our differential diagnosis? Beautiful. So someone says cerebral tumor. Beautiful. Cerebral tumor. Or it could be an abscess. That's why I said it could be with or without fever. So that's a brain tumor. Okay. And it could also be a brain abscess if there is fever. The patient looks very sick. Okay. Doctors, next differential. Patient has headache plus seizures, and the patient is a young woman on oral contraceptive pills. In fact, today I asked this question to the MedCognito students in our private executive WhatsApp group. Headache plus seizures plus a young woman on oral contraceptive pills. And some people got it right. I was like, wow, I really like this. Headache plus seizures plus young woman on oral contraceptive pill. What is your differential diagnosis here? And I even gave you a hint that it is not an arterial stroke, but it's still a brain clot. What's the answer here? What's the answer here? What's the answer here? What's the answer here? The answer is cerebral venous thrombosis. 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 Next, mimic. Patient had normal imaging, sudden paralysis, and the patient is going through a psychological stress. But when you do the CT scan, it's normal. But the patient has paralysis, and the patient has a psychological stress that patient is going through. What is the answer? What is the answer? What is the answer? Normal CT scan, sudden paralysis, psychological stress. What is the answer? What is the answer? Beautiful. Dr. Erica Teleg says functional. Beautiful. So this patient has a functional deficit, or what we call conversion reaction. Okay, it's a functional deficit, or what we call a conversion reaction. It's a functional deficit. Functional deficit. CT scan is normal, but the patient has paralysis. And when you take a deeper history, it looks like the patient is going through a psychological stressor. Okay. Severe hypertension with confusion and seizure, which can mimic stroke. What is your diagnosis? Severe hypertension with confusion and seizure. What's your differential diagnosis? What diagnosis are you thinking about? What diagnosis are you thinking about? Severe hypertension, there's confusion, there's a seizure. What diagnosis are you thinking about? Beautiful, beautiful, Dr. Luke. Beautiful, 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 Dr. Ben. Beautiful. Hypertensive encephalopathy. Doctors, you see the way we are quizzing you. This one, if you know, you know. If you don't know, you don't know. But with all the mimics we're going through, please make sure that after that you have to read what's the difference between this and seizure and a stroke, right? Good. Hypertensive encephalopathy. Next one, the patient had a fall, confusion some days later, and when you do the CT scan, you see a crescent-shaped lesion on the head CT scan. The patient is probably an elderly man. He fell. He's having confusion days after. And when you do your CT scan, you see a crescent on CT. What's the answer? I see Dr. Chinwe Wealth says subdural hematoma. Beautiful. Subdural. Okay. Next one. The patient has a mitochondrial disorder. The patient has lactic acidosis and stroke-like episodes. Mitochondrial disorder, lactic acidosis, and stroke-like episodes. Mitochondrial disorder, lactic acidosis, and stroke-like episode. What's the answer? Mitochondrial disorder, lactic acidosis, and stroke-like episodes. What is the answer? Doctors, as I said, while we are going through this, please click on the like and subscribe button, okay? Let's grow MedCognito YouTube together. We are doing this for you, with you, through you, and by you. So let's move it to 2,590 subscribers at least. Okay. Oh, wow. We already have 2,580. So let's do 2,600 subscribers by the end of this class. 2,600 subscribers by the end of this class. Okay. 2,600 subscribers by the end of this class. Okay. So let's go. So what's the correct answer? Some people are saying diabetic ketoacidosis. No. The answer is mitochondrial encephalopathy with lactic acidosis and stroke-like episodes. Okay. That is usually how it is described. Okay. Now, you have a patient with sudden weakness and the patient is also on insulin. What's your differential? Patient is sudden weakness and the patient is on insulin. Sudden weakness and the patient is on insulin. Sudden weakness and the patient is on insulin. Sudden weakness, the patient is on insulin. And this can mimic stroke. Beautiful. Hypoglycemia. Hypoglycemia. So it's a toxic metabolic disturbance like hypoglycemia. Next one, acute confusion, fever, aphasia or seizure, and the patient has vesicles around the lips. Vesicles around the lips. Acute confusion, fever, aphasia or seizure, and the patient has vesicles around the lips. Vesicles around the lips. Vesicles around the lips. What's the correct answer? Acute confusion, fever, aphasia, or seizure with vesicles around the lips. Beautiful. The nomad. Beautiful. This is encephalitis, viral encephalitis, like HSV encephalitis. Okay. Next question. Next question. Confusion, ataxia, eye movement problems, and in a patient with alcohol use. Confusion, ataxia, eye movement problems in a patient with alcohol use. Confusion, ataxia, eye movement problems in a patient with alcohol use. Beautiful, beautiful. I see the people. Wernicke's encephalopathy. Wernicke's encephalopathy. Wernicke's encephalopathy. Beautiful. Doctors, so we are done with that game. We are done with the differentials game. So now you've learned all your differentials of stroke, basically. That's what you've just done in this exercise. You learned about your Wernicke's encephalopathy. You learned about your encephalitis. You learned about your hypoglycemia. I didn't want to just give it out like that. That's why I took you through. You learned about subdural hematoma. You learned about hypertensive encephalopathy. You learned about conversion disorder. You learned about cerebral venous thrombosis. You've learned about CNS tumor or abscess. You've learned about seizure or toss paralysis. You've learned about migraine with aura. And I didn't even have to give you anything. I just gave you the cases and you just dealt with it. That's beautiful. That's the power of how we are learning here. Please don't forget that at the end of this class, we are going to do our active record of everything we've studied. So please, that one, I'll not give you MCQs. I'll just give the question and you provide me the answer, right? Okay. So initial assessment and management of stroke. So, the way we talk about heart attacks, right? The way we talk about heart attacks. And I want to make sure that we make things super simple. So brain or stroke is what I also call brain attack. The way we call heart attacks, right? Stroke is what we call a brain attack. And remember that in heart attacks, every second counts. Therefore, in a stroke as well, every second counts. When you see a stroke, your mission in the MCCQE1 and the NAC is to stabilize the patient, identify the stroke type, and decide if reperfusion is possible. Okay? And decide if reperfusion is possible. In a stroke patient, just stabilize the patient, identify the type of stroke, and then decide if reperfusion is possible. So, the three main vital signs of concern if a patient has stroke is number 1, blood pressure. Number 2, the breathing. And the breathing, we are focusing on the oxygen saturation. And number 3, the temperature. These are the three main vital signs we are concerned about. In a patient with stroke, the three main vital signs we are concerned about are blood pressure, the breathing, and then the temperature. Okay? Now, essential vital signs, as I said, the blood pressure. In stroke, the blood pressure is often high. But most of the time, it's also protective to keep the brain perfused. But if the blood pressure is too high, then there's a risk of bleeding or damage. And so in a patient with stroke, don't be in a hurry to lower the blood pressure quickly, unless there are these three things. Number 1, the blood pressure is just severely too high, like 250 over 150 or something, Or number 2, the patient's a candidate for thrombolysis. And number 3, you have done a CT and you have confirmed that this patient has a hemorrhagic stroke. Then in that case, you want to bring down the blood pressure. So don't rush to lower the blood pressure unless the blood pressure is severely high. Because elevated blood pressures in acute stroke can be protective. We have what you call the umbra and the penumbra, right? But I'm not going to go into details about that. So, remember that the blood pressure is already high in this patient. A lot of patients with stroke, they may have hypertension, right? So, if the patient has a stroke and the body is still trying to get blood to those tissues of the brain, and you try to drop the blood pressure quickly, what is going to happen is that you're even going to cause sudden death of those tissues that the body was trying to get blood to. But when do you want to bring down the blood pressure? If the blood pressure is just too high, number 1. If the candidate is a candidate for thrombolysis. And number 3, hemorrhagic stroke is confirmed with CT scan. Okay. Now the breathing. What's it about the breathing? Stroke can affect the breathing of the patient, right? Especially if there's a brainstem stroke or increased intracranial pressure. So you want to watch out for slow or irregular breathing, vomiting or gargling sounds, and low oxygen. Look, if in a case of stroke, the airway of the patient is threatened, what you need to do is that you need to make sure that you intubate the patient. So stroke plus airway threat, think about intubation. That's something I want to draw attention to. And then the temperature. Fever is the number one enemy of the brain during stroke. Remember that every degree rise of temperature can worsen brain damage. And so the golden rule in stroke is that keep the brain cool and calm. Aim for normal body temperature. Okay? If you have a patient with stroke and the temperature is very high, be very careful. Every degree rise of temperature will worsen the brain damage. So now let's go into history and physical exam in the case of stroke. When you have a patient with stroke, we are going to focus on history mainly. If you have a patient with stroke, first question is, when was the last time the patient was found normal? And this is what we call the stroke clock. So when was the last time the patient was found normal? You realize that this is a question we ask in the emergency room all the time. Was there any seizure history? Because we know that one of the differentials of stroke is thoughts paralysis. Is the patient on insulin? Why? Because one of the differentials is hypoglycemia. Is the patient on any oral diabetes medications or any drug use? Is the patient, did the patient just experience any trauma? And is there any hysteria or psychiatric illness? Why? Because of conversion disorder. You also want to ask about high blood pressure, diabetes, hyperlipidemia. You want to ask about all these things. Now, is it ischemia or hemorrhage? The next best investigation in a patient with stroke is nothing but a non-contrast CT scan of the head. Next best investigation, let me say it again, please write it down. Next best investigation in a patient with stroke, get a non-contrast CT scan of the head. Why do you have to get a CT scan first? Because CT scans can be done quickly. A CT scan can help you to rule out a bleed. A CT scan is widely available in Canada. If there is hemorrhage, you realize a white hyperdense area on the CT. So if you go back to the images I showed when we're talking about intracerebral hemorrhage, you will see that kind of white thing. If there's ischemia, the brain CT scan may look normal earlier on, but eventually you see some changes. Okay, so the point I want to make here is the highlighted point, non-contrast CT scan of the head. Now, what is the next best step in your evaluation of a patient with stroke if the initial CT is normal and you are still suspicious? Remember, I told you that we'll be talking about the role of MRI. If CT is normal but you are still suspicious, that is when you want to get your MRI. CT is normal, but you go like, I don't feel comfortable about this. I don't feel comfortable about this. Then get your MRI. What about if you are suspecting subarachnoid hemorrhage and the CT scan is negative? Then do your lumbar puncture. Doctors, we are talking about some very critical pearls here. CT is normal, but you go like, no, this patient still has a stroke. I'm convinced with my examination and my history. Get an MRI. CT scan is fine, but you're thinking, this patient may have subarachnoid hemorrhage. Please arrange for a lumbar puncture. Doctors, again, let's take a pause and let's evaluate. How has it been so far? Tell me. How has it been? Let's evaluate and talk before we move on to the next line. Because from here, we're moving on to whether or not the brain can be perfused. Okay? Dr. Yasoti says what? Dr. Boni teaches in such a way that when confronted with a question, you are not confused about what the answer should be and also why the wrong answer is correct. Yeah. Thank you. Says thank you for this. Yeah. So we want to make sure that it makes a lot of sense. And then others are saying brilliant, an embolic and hemorrhagic stroke can coexist in a patient. Somebody's asking, well, it may, but we are dealing with a board exam, right? And board exam, no one is there to confuse you. It makes sense. Okay, so Dr. Noel says perfect. Okay, so let's go back to this. Can the brain be reperfused or not? That's the question. Can the brain be reperfused or not? Remember that time is brain, right? Time is brain. And the longer the brain is without blood, the more the cells will die. The longer the brain is without blood, the more the cells will die. So, thrombolysis, are you going to do thrombolysis or are you going to do thrombectomy? IV thrombolysis is given within 3 to 4.5 hours of symptom onset, okay? And it must meet strict eligibility criteria. And we'll be talking about the eligibility criteria for altiplase, and the kind of IV thrombolysis you can give is what we call altiplase, okay? The patient must meet a very, very strict criteria. Now, what about mechanical thrombectomy? In mechanical thrombectomy, you use a stent to retrieve or pull out the blood clot. So remember, we're talking about, atrial fibrillation and the fact that it can be like a missile sending the blood clot to the brain, right? So it is used for large artery occlusions in anterior circulation, and it can be done up to 24 hours in some well-selected patients. Not all patients, but in some well-selected patients, okay? Now, so let's go through the quick steps about evaluating of a patient with stroke. Quick steps. First, the patient may present with facial droop, arm weakness, speech slurring. That's what we call the FAST, right? Evaluate the airway. If airway is not protected, patient is vomiting all over, patient is not conscious, you're concerned, intubate. Blood pressure, don't lower the blood pressure quickly unless the patient is going to be on thrombolytics or the blood pressure is just too high, right? Or you've confirmed hemorrhagic stroke. Temperature, cool the patient down. Make sure you get your CT scan, non-contrast CT scan quickly, and then make a decision. If it is ischemic stroke, are you going to do thrombolytics or thrombolysis, or are you going to do thrombectomy? Remember that thrombolytics can be done between 3 to 4.5 hours after the stroke when the patient was last found normal, right? So let's do a quick review of intravenous thrombolytics. You have to know the inclusion and the exclusion criteria for thrombolytics. Okay, so you've done your CT scan. You are sure that this is not a bleed. Now you're going to do your thrombolytics. The inclusion criteria is that the patient must have ischemic stroke, which is leading to measurable neurologic deficit, maybe arm weakness, something. Onset is less than 4.5 hours before you begin the treatment. Now, if the exact time of the stroke onset is not known, use the last time the patient was known to be normal as their neurologic baseline. Okay? And the patient must be more than 18 years of age. This is the inclusion criteria for thrombolytics, IV altiplase. Now, you must also know the exclusion criteria for thrombolytics in a case of stroke. This one, why are you not going to give thrombolytics? So if you're writing MCCQE1, if you're writing NAC, if you're writing TDM, that's the therapeutic decision making, you must know this by heart. Inclusion and exclusion criteria for thrombolytics in a patient with stroke. You must know it like the back of your palm. If you are waking up, you must be able to talk about it. So let's do that quickly. Number one, what is the exclusion criteria? Ischemic stroke or severe head trauma in the previous 3 months. Don't give IV altiplase. Previous intracranial hemorrhage. Intraaxial intracranial neoplasm. Brain tumor. Gastrointestinal malignancy. Gastrointestinal bleed in the last 21 days. Don't give. Intracranial or intraspinal surgery within the prior 3 months. Don't give IV thrombolytics. Okay? Symptoms that are suggestive of subarachnoid hemorrhage. Don't give your IV thrombolytics. If the patient's blood pressure is more than 185 millimeters of mercury for systolic or more than 110 millimeters of mercury for diastolic, don't give. If the patient has active internal bleeding, don't give. If the patient has infective endocarditis, don't give IV thrombolytics. Okay? If the patient has stroke known or suspected to be associated with aortic arch dissection, don't give. If there's acute bleeding diastasis, don't give your IV thrombolytics. Doctors, please, is it making sense? So we've talked about the inclusion criteria, and now we are talking about those who are excluded from IV thrombolytics. All right? If the platelet count is less than 100,000 per millimeter cube, don't give. If the patient is on INR, on an anticoagulant with an INR of more than 1.7, or a PT of more than 15 seconds, or an APTT of more than 40 seconds, please don't give. If the patient has been on low molecular weight heparin within 24 hours to treat things like acute coronary syndrome or venous thromboembolism, don't give. However, this exclusion does not apply to prophylactic doses of low molecular weight heparin. So if low molecular weight heparin is being given for active treatment, then don't give your IV thrombolytics. Doctors, are we good? Because now we're going to get into the active recall. So we just talked about IV thrombolytics, inclusion criteria and exclusion criteria. When to give it, when not to give it. And now we're going to get into our active recall class. So now we're going to quiz you on everything you've learned. This time, I ask the question, you provide me the answer. I ask the question, you provide me the answer. I ask the question, you provide me the answer. Okay? So are you ready for it? Are you ready? Are you ready? Okay, good. But before that, remember that tonight we have a class, pediatrics. We have a class tonight, 6:30 p.m. Ontario time. And when you register for the class, you're going to get all these things in your portal right away. Okay? And you can go into, so if you go to the pediatrics portal and you click on that, it's going to open up everything for you. And you can start reviewing. You can even start reviewing previous classes before you attend the class. And all these portals and many more are there. You even have a portal for mock exams as well. Okay? And you're going to get line upon line review, and all this comes up to $7,860. However, you can get all of this for just $2,199 for 6 months. But if you want to go monthly as well, you can just pay $420 every month, and you can get access to everything again. And so, doctors, if you're interested in it, touch base with me on WhatsApp. I prefer WhatsApp because, as I said, if you are any part of the world, you can connect with me. +1 306 891 5649. +1 306 891 5649. Now, let's run into the active recall. The first question: what are the two main types of stroke? Please type your answers. Let's go. I'm just going to give you 5 seconds, and then we move on to the next question. What are the two main types of stroke? What are the two main types of stroke? What are the two main types of stroke? Beautiful. So we have the two main broad categorizations are ischemic and hemorrhagic. Is it that the road has broken and burst, or there's decreased blood supply? That's the two main types. Now, what are the two types of ischemic stroke? So we have the two main types of stroke, then we have the ischemic and the hemorrhagic. Now, under the ischemic, what are the two types of ischemic stroke? Let's go. What are the two types of ischemic strokes? We've learned everything today in class. Let's go. Thrombotic and embolic. Beautiful. Now, which stroke subtype presents with coma, vomiting, and very high blood pressure? Let's go. Now we are just putting everything together. We've learned. It's like we've cut all our ingredients, and now we're putting everything together to make some nice Nigerian amala. We are making some nice Nigerian amala, or we are making some nice Iranian dish, or some nice Indian biryani, right? That's the name of that Indian food. It's called biryani or something. So nice, right? Okay. So what stroke subtype presents with coma, vomiting, and very high blood pressure? Beautiful. Intracerebral hemorrhage. Intracerebral hemorrhage. Next question. What kind of headache is classic for subarachnoid hemorrhage? What type of headache is classic for subarachnoid hemorrhage? What type of headache is classic for subarachnoid hemorrhage? And doctors, while we are solving these questions, please don't forget to click like and subscribe. Like and subscribe to our YouTube channel. So it's a thunderclap headache, or the patient will say it's the worst headache of my life. Okay, good. Which stroke subtype is more likely in patients with atrial fibrillation? Which stroke subtype is more likely in patients with atrial fibrillation? Which stroke subtype is more likely in patients with atrial fibrillation? Doctors, talk to me. Which stroke subtype is more likely in patients with atrial fibrillation? Embolic stroke. Beautiful, beautiful. Stroke mimic with malnutrition or alcoholism. Which stroke mimic presents in a patient with malnutrition or alcoholism? Which stroke mimic presents in a patient with malnutrition or alcoholism? Which stroke mimic presents with malnutrition or alcoholism? Wernicke encephalopathy. Beautiful. What are the 2 signs that a patient may need to be intubated during stroke care? What are the 2 signs that a patient may need to be intubated during stroke care? What are the 2 signs that a patient may need to be intubated during stroke care? Someone says breathing compromise. So you can see your comments on the screen now. Look this. What are the 2 signs that a patient may need to be intubated during stroke care? Number 1, vomiting or decreased consciousness. So like that's if the airway is compromised, right? The patient is unconscious and maybe vomiting, there's a risk of aspiration. And you don't want a stroke patient to also aspirate. Okay. Next question. What is the first imaging test in suspected stroke? What's the first imaging step in suspected stroke? What's the first imaging step in suspected stroke? Yes, but let's be very sure. Like we say CT, but it should be non-contrast CT of the head. Non-contrast CT of the head. Non-contrast CT of the head. Okay, good. If you suspect subarachnoid hemorrhage, but CT is normal, what is the next best step? If you suspect subarachnoid hemorrhage, but CT is normal, what's the next best step? Remember, you suspect subarachnoid hemorrhage, but CT is normal. What's the next best step? The next best step is that you want to do your lumbar puncture. What drug is used for IV thrombolysis? What drug is used for IV thrombolysis? What drug is used for IV thrombolysis? And doctors, please remember, after the class, usually after class, I get a lot of messages and calls. Remember, it is first come, first serve, right? So if you want me to call you, kindly send me a WhatsApp right now, because we are wrapping up the class. Now we are doing the active recall and we are done. Okay. So if you want me to contact you, kindly send me a message on WhatsApp currently at +1 306 891 5649. +1 306 891 5649. So the answer is altiplase. Okay. Altiplase. And what's the time window for altiplase use? What's the time window for altiplate 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 use? Good. Within 3 to 45 hours of symptom onset. Beautiful. Look, you guys are getting it. And what is the extended time window for thrombectomy in well-selected patients? What's the extended time window for thrombectomy in well-selected patients? What's the extended time window for thrombectomy in well-selected patients? Up to 24 hours of last seen normal. Ladies and gentlemen, doctors of the noble profession, thank you very much for spending your afternoon with me. It's been a wonderful class, great participation in the class, and I really, really enjoy it. Thank you. We've spent 1 hour, 35 minutes studying on stroke. I don't think any stroke case should beat any of you ever in the MCCQE1 or the NAC OSCE class. As I said, you can reach out to me right now at +1 306 891 5649, +1 306 891 5649. I've seen that some people are sending me messages. +1 306 891 5649. I will call you as soon as the class is done. Thank you, doctors. Thank you very much. Please share this video. It's going to be in our YouTube channel. Go to the live portal, and so many videos there for you to study and for you to enjoy. Okay, so if you go to MedCognito and then you click on live, you'll see everything there. Thank you very much. God bless you. Spend time with the people you love. Take care of yourself. Study hard. Go out there. Ace the exam. You'll be happy. Your family will be happy. Your wife will be happy. Your children will be happy. And I will be happy as well that we were able to walk alongside you in this particular journey. You want to join our class as well? We are here to help. Just shoot me a WhatsApp message right now. Some people have started calling already. I'll get in touch. Someone says, we are immune to stroke now. Beautiful. That's Dr. Druvi. Someone also says, thank you so much. You're amazing. God bless you, Dr. Bruni. And then Dr. Onyinyi Okonkwo says, thank you so much, Dr. Bruni. Thank you guys for spending your afternoon with me. I really appreciate it. And we'll keep making sure that we bring you the best of content and the best of preparatory material for the MCCQE1 exam. Remember, the best way to get the best value from MedCognito is to join our live class. So I invite you to do so. God bless you. Enjoy your day. Bye-bye. Bye-bye. Bye-bye.